Please start.
Good evening, everyone. I welcome you to the Journal Club for the Young Turks. And today we have an interesting topic on frozen embryo transfer. And our expert for the evening is Dr. Neeti Tiwari, ma'am. She's a senior consultant in Sir Gangaram Hospital. I welcome you, ma'am. Thank you so much for giving us time for the Journal Club.
Thank you, Ankita.
And I Thank you. And I would like to welcome Dr. Monica Rajput. She's done her DM reproductive medicine from AIMS New Delhi, and she's working as a consultant reproductive medicine in Yashoda Medicity. Dr. Monica, please, you can start the journal club.
Yeah, thank you so much, Dr. Ankita. Thank you, Dr. Neeti ma'am, and thank you Inchai IFS for giving me this opportunity to present wonderful paper today. And firstly, I would like to wish all of us a happy World IVF Day 2025. I'm starting with the screen sharing. Is my screen visible?
Not yet, not yet.
There's some problem.
In the
Dr.
meantime,
Monica,
I would
you
like
can
to
just
request. Okay, sorry,
you
carry
can
on.
just click on the green button, share screen button on the Zoom. And you are on mute.
Dr. Monica?
Is it visible now?
No,
No,
not yet.
ma'am. Please come to the Zoom and then click on the green button, share button. Click that window which you want to share and share.
What is the problem which you are facing, Dr. Monica?
Ma'am, I'm like able to go on the option for sharing screen, but then I don't know why it is not being shared. And there is no network issue from like my side here.
Yeah, we can see you, we can hear you, so
Yes,
there must
ma'am,
be
yes,
no
ma'am.
network issue. But your screen is not seen.
Monica, do you want to leave the meeting and join back? Will that help? Admin, if you can
I
help
think
her,
I'll do that.
please.
Yeah.
You can
I'll,
try by rejoining.
yes, I'll do that.
Happy World IVF Day to everyone. All the new budding IVF specialists in this group. I think she has joined again. No?
Not yet.
Acha, she's waiting there.
I'm now click on share screen button on the Zoom
Yeah, I have clicked that.
and then click that window which you want to share. Then click on share.
No, I'm doing that, but then I'm not able to.
Or you can double click on that window which you want to share. Ma'am, if you are not able to share, you can just share the PPT with me. I will share on behalf of you.
Yeah, can you send me your mail ID?
I am just mail ID, or should I send you my WhatsApp number?
WhatsApp number will do, yes.
I apologize to the audience for the delay. Just wait for 5 minutes. We are working out the thing. Thank you. Sorry, Dr. Neeti ma'am also. Dr. Monica, are you there?
Yes, yes. So shall I start?
Yeah,
Neeti
please.
ma'am, can I start?
Yeah, please do.
Thank
So
you so much, ma'am. Thank you for, and sorry for the delay,
sorry
everyone.
for the delay. Very good evening to all of you. So my today's journal club is from Human Reproduction Open with impact factor of 6.3 as of 2024. So the paper is Natural Proliferative Phase Frozen Embryo Transfer, a new approach which may facilitate scheduling without hindering pregnancy outcomes, published in 2024 November. I think it's having some problem. It's not moving ahead.
They will have to move. Yeah, you have to tell them to move.
Okay. So as we all know that in the past decade, world has moved, in fact, is still moving towards FET cycles due to improved cryopreservation techniques, confidence to freeze all embryos rather than the second best ones, and due to increasing use of GnRH agonist trigger, due to further increased use of genetic screening, that is PGT, and trend towards few number of embryos transferred, hence freezing surplus embryos. Please move ahead. So as we all know that FET has been increased due to its ever-mounting list of indications, continuous optimization of the cryopreservation techniques, and increased reassurance regarding both neonatal safety and subsequent risk for congenital abnormalities is still unproven. So still there is controversy regarding the best FET protocol.
Just tell them next, Monica. You just
Okay, ma'am.
keep saying
Okay.
next so they will move faster. Yeah.
Yeah. So these are the predictors, as we all are very well aware of, for the success of frozen embryo transfer. So we need three good predictors, that is good quality embryos, receptive endometrium, and a crosstalk between embryo and the receptive endometrium. Next, please. There are three types of FET cycles: natural cycle, including two, and modified natural cycle, which we will be discussing further. Programmed or the artificial FET, that is hormone replacement cycle, HRFET, and stimulated FET cycle, which gets stimulated after giving the oral ovulagens, either letrozole, preferably letrozole. Next. So this is the schematic diagram to show how we actually start with the artificial cycle, and we all are very well aware of that we give estradiol in the doses of 6 milligram to 12 milligram per day. Once the lining is more than 7 mm, P4 is less than 1.5 nanogram per ml, then we start the progesterone, usually vaginal progesterone in the doses of 400 milligram BD is given, which was given in the current article, and then they go ahead with the frozen embryo transfer. Next. Can we have in a slideshow view? But the pros of the HRFET cycle is that it requires minimal monitoring, and we have very good flexibility in HRFET cycle scheduling and effective approach. But the negative side is that it comes with higher cost, potential risk of long-term estrogen supplementation in some females, with lower implantation and higher miscarriage rates as proven by literature in comparison to natural FET cycles, and with a higher cesarean section delivery rate. Next.
And now you can also move the screen. You can check.
Okay. It's still not working. So artificial cycles. So artificial cycles may circumvent the physiological vascular adaptation during pregnancy, and they increase the risk of pregnancy-induced hypertensive disorders and pregnancy-induced diabetes mellitus due to absence of corpus luteum production. Next, please. In true natural cycles, contrary, the endometrium proliferates along with the follicular development until natural ovulation occurs, and we start monitoring from day 8 or day 10 of the cycle with serial E2LH and P4 monitoring at least till when the leading follicle reaches the size of 16 to 17 millimeter. And ovulation usually occurs a day after when LH has risen to 18 international units per liter, especially when accompanied with concomitant rise in the serum P4 more than 1.5 nanogram per ml. So this is the schematic diagram showing both true natural and the modified natural cycle. In true natural cycles, we are not giving any kind of ovulation trigger, and we completely rely on the natural growth of the follicle, and we follow the LH surge. So the day 3 embryo transfer is done on LH plus 4 day, and the day 5 transfer is done on LH plus 6 day. So here the day of ovulation is considered as the day of pickup. While in modified natural cycle, HCG as ovulation trigger is given to induce ovulation, and day 3 transfer is done on HCG plus 5 day, and day 5 ET is done on HCG plus 7th day. But the disadvantages of natural cycle FET that it requires more visits to the clinic with decreased flexibility for scheduling of FET cycles, and it's difficult to detect the proper timing of ovulation due to inconsistency of current definitions of the LH surge. And there is also increased risk of cycle cancellation in non-ovulatory females. Next, please. HCG in modified natural cycle generally overcomes the difficulties related to identification of LH surge, but it implies an extra cost and associated with conflicting data regarding the clinical success, possibly due to embryo endometrium asynchrony generated when HCG is administered concomitantly with an unidentified spontaneous LH surge. Next, please. So whether FET is occurring under the more physiologically prepared endometrium in the natural cycle might result in higher pregnancy rates, decreased maternal and neonatal morbidity, and whether it's patient and doctor friendly is still a matter of debate. Next, please. So this is the current schematic diagram being used in the current study, that is NPP-FET protocol, Natural Proliferative Phase FET protocol. So here what they do, they completely rely on the natural growth of the follicle, and no additional exogenous estrogen is being given here, and the progesterone is started irrespective of the size of the dominant follicle. When ET is more than 7 mm, when P4 is less than 1.5 nanogram per ml, and then vaginal progesterone 400 milligram BID has been started in this current study. So vaginal progesterone was initiated during proliferative phase as soon as ET was at least 7 mm, and ovulation is ruled out regardless of the mean diameter of the dominant follicle. So the study question in the current study is, how does natural proliferative phase strategy for frozen embryo transfer compared with the conventional AC and natural endometrial preparation protocol is better in terms of live birth rates or not? It was a retrospective single cohort study, and it was conducted at the Lisboa city between 2010 to 2022. Total 5,791 cycles were included, corresponding to 3,625 patients, and they were subdivided into three categories: conventional HRFET protocols, then NPP FET protocol, and a true natural cycle protocol. Inclusion criteria were the subjects included underwent at least one FET at blast stage with maximum of 2 embryos being transferred, and those using exogenous ovarian stimulation, ET less than 7 mm, or any uterine abnormalities were ruled out. So the primary outcome was live birth rate, and secondary were positive HCG rate, clinical pregnancy rate, miscarriage rates. Also the perinatal outcome in like in terms of first trimester bleeding, second trimester bleeding, and GDM and GHD were also monitored. All embryos were obtained after IVF, either using autologous or donated oocytes, and the mode of fertilization was both either conventional IVF or ICSI. And all the good quality embryos were selected for vitrification as per the ASE-BIR criteria. So until 2014, embryos were mostly transferred and cryopreserved at cleavage stage unless PGT-A was performed, in which case embryos were cryopreserved at the blast stage. Between 2014 to 2016, if there were more than 3 embryos available at day 3, then all the remaining embryos following transfer were cryopreserved for later at the blast stage. From 2016 onwards, all transfers were generally performed at the blast stage, and couples were routinely advised to perform single embryo transfer. So how they went ahead with the endometrial preparation protocol. In NPP cycle, ET was started being monitored from 8th day, and whenever ET reached at least 7 millimeters, vaginal micronized progesterone was initiated at the dose of 400 milligram every 12 hours if serum P4 levels were less than 1.5 nanogram per ml. So it was irrespective of the size of the dominant follicle and circulating LH serum levels. While in AC and NPP cycles, FET was scheduled on the 6th day of progesterone exposure, but in true natural cycle, progesterone was started from the night of ovulation and transfer was scheduled as compared to, like it was similar to the P4 exposure, the day of P4 exposure as in non-NC cycle. So on the day of ET, they routinely measured P4 in all the patient and additional exogenous P4 was given in the form of intramuscular 100 milligram when the P4 value was less than 8.5 nanogram per ml. Luteal support was interrupted at either 8th week in natural cycles or 11th week in NPP and AC cycles. So let's not go into detail about the statistical analysis. I think we can move further.
No. Just a minute. Monica, this
Yes,
was
ma'am.
important. Just go back to your last slide. This confounder adjustment is very important because the population
Okay,
is
ma'am.
so heterogeneous.
Yeah,
I
yeah,
should
yeah.
mention this that they did confounder adjustment, है ना?
Yes,
Because
ma'am.
they took almost all patients.
They took almost all
With
patients and
PGTA,
initially,
without PGTA, they took donors,
yes,
autologous,
ma'am.
all kind of. So let's talk about this one.
Yeah. So in statistical analysis, baseline between group comparisons, they were performed using univariable logistic or linear generalized estimating equations regression to account for the clustering derived from FET cycles using embryos derived from the same fresh treatment cycle. And for confounder adjustment, it was performed using multivariable GEE regression analysis, adjusting for the potentially relevant confounding variables like female age at the oocyte retrieval, oocyte source, whether it was autologous without PGTA versus autologous with PGTA, and versus donor oocyte cycles. Number of oocytes retrieved or donated, then embryo developmental stage, day 5 versus day 6, number of embryos transferred, quality of the best embryo transferred, A versus B or C, and the year of treatment because it was long study which continued for around 5 years. An additional sensitivity analysis was performed dichotomizing the sample in the following subgroups. Like oocyte age was then further divided into less than 40 and more than 40 in two categories, BMI less than 25 and more than 25 kilogram per meter square. Source of oocyte was again divided into autologous without PGTA, autologous with PGTA and or donated. FET cycle rank first versus others. And endometrial thickness was divided into two categories, less than 9 and more than 9. 9 or more than 9. And the status software version was 16. So initially, while starting the study, 8,566 FET cycles were included. But after being excluded, after excluding all the patients as per the exclusion criteria, 5791 FET cycles were finally included for result analysis, out of which 3,216 were true natural cycles, 349 only were NPP FET cycles, and 2,226 were HR FET cycles. So this is the breakdown of FET cycles year-wise. And as we can see, maximum number was maximum patient underwent natural cycle, two natural cycles. But in this two natural cycle group, even 44% were modified NCs, where exogenous HCG was administered to induce ovulation. So moving on to baseline clinical characteristics analysis, as we can see that the serum progesterone on the day of FET, if we see the serum progesterone on the day of FET in HR-FET cycles, it was 10.4 nanogram per ml baseline. In NPP, that is natural proliferative phase cycle, it was 20.6. And in two natural cycles, it was 20.5. Rescue progesterone was given in 26.1% cases in HR-FET cycles, 2.9% only in NPP cycles, and 1.3% in true natural cycles. Moving on to pregnancy outcome result analysis. So the significant values were for clinical pregnancy rate, miscarriage rate, and live birth rate, where it was 50.5% in HRFET cycles, 57% in NPP, where no monitoring for the dominant follicle or for LS surge was done, and 54.4% was in true natural cycles. Again, the miscarriage rate was lowest, 19.7% in the NPP cycle, and live birth rate was 38.4% in HRFET cycles, 49.1% in NPP cycle, and 45.2% in natural cycles. So it was clinically significant difference. Moving on to perinatal outcome, if we look at the first trimester bleeding, then it was 37.6% in HRFET cycles, 17.4% in natural proliferative phase cycles, and 14.7% in true natural cycles. Again, gestational hypertensive disorders and gestational diabetes both were lower in the natural NPP cycles and NC cycles when we are comparing to HRFET cycles. But the difference for gestational hypertensive disorder was clinically significant. It was 9.4% in NPP cycle, 8.6% in natural cycles, and 14.5% in HRFET cycles. So the matter being discussed here, which is the best FET protocol, which is still in controversy. Please move next. This was the review article which came in Fertility Sterility in November 2022. And it actually gave us the idea that what is the impact of different endometrial preparations protocols before FET on pregnancy outcomes. But since it included low quality and only few RCTs, so till date, no strong evidence is actually available to support the use of one preparation method over another. But yes, this review article gave us the robust data that shows clearly protective effect of the natural FET cycles against long-term OBS complication, mainly hypertensive disorders and gestational diabetes mellitus, which is lower rates in the true natural cycles or modified natural cycles as compared to AC cycles. Now, this is the second study. Move ahead. Move next. Yeah. So this was the second study, just one slide earlier. It was published in European Journal. Here is not visible to me, which showed that the objective of this study was to assess whether a modified natural protocol for FET without triggering the ovulation, but with the luteal progesterone support, disconnects the timing of embryo transfer is better from the timing of LH surge, can achieve a higher pregnancy rate or not. And further. So the conclusion, to conclude, the proposed modified natural protocol being similarly discussed in the current study, which utilizes progesterone luteal support but not trigger ovulation, maintains a high pregnancy rate that is 54.7%, while providing flexibility at the same time regarding the day of the transfer disconnected from the day of the LH surge. So this was the proof of concept study which was published earlier in 2022 in European Journal before the current study. Next. So, as we can see that NPP in the current study being discussed presents an alternative protocol to the two most commonly used HRFET and true natural cycle protocols, as it combines the advantages of transfer scheduling of the HRFET protocol with potential clinical benefits associated with the natural cycle protocols. Next. So what are the advantages of natural phase proliferative FET protocol? Current study confirms the hypothesis that NPP may provide a high live birth rate like the natural cycles. And this retrospective analysis also showed lower miscarriage rates for the NPP protocols. And it reiterates the conclusions found in the previous literature describing potentially worse clinical outcomes, that is higher miscarriage and low live birth rates associated with the HR hormone replacement cycles. So is corpus luteum really formed in NPP FET cycles or not? We all know that corpus luteum produces not only progesterone and estrogen, but also relaxin and VEGF, which are important vasoactive molecules, and they help in further initial residualization, implantation, angiogenesis, and they actually help the maternal physiology for hemodynamic adaptation. So absence of this corpus luteum, which commonly happens, which occurs or which is the part of hormone replacement cycles, actually contributes to the higher rates of hypertensive disorders and gestational diabetes mellitus too, observed with HRFET protocols. In natural phase proliferative protocols, progesterone exposure was started before CL formation, corpus luteum formation, and corpus luteum was frequently observed during the early gestational scan when these patients were monitored after getting pregnant. Formation of corpus luteum may be induced by either the beginning of higher doses of exogenous progesterone, because here we are starting higher dose, that is 400 milligram 12 hourly is in the starting phase, or corpus luteum may have been formed by the non-opposition of the natural evolution of the growth and luteinization. But in current study, incidence of gestational hypertensive disorders is comparable to natural cycle, supports hypothesis that ovulation might have occurred in such protocol too. So is there any role or minimum threshold of the luteal serum P to ensure embryo implantation? So serum progesterone levels were routinely assessed on the day of transfer, as we do in HRFET cycles, and if below 8.5 nanogram per ml, a rescue intramuscular progesterone 100 milligram was initiated. Use of luteal phase progesterone and rescue strategies may still be insufficient to prevent the increased risk of miscarriage in HRFET cycles when compared to natural cycles. And this strategy of individualized luteal phase support has been shown to enhance the live birth rate in HRFET protocols. So this was the study published in Fertility Sterility, that serum luteal phase progesterone in women undergoing frozen embryo transfer in assisted conception. It was a systematic review and meta-analysis, and it showed that ongoing pregnancy or further to conclude. Next slide. Yeah, so it showed that among the studies analyzing the serum progesterone level, where it was less than 10 and a higher serum progesterone level was associated with increased rates of ongoing pregnancy or live birth rates, higher chances of clinical pregnancy rates, and lower chances of miscarriage. Next. To conclude, there may be a minimum clinically important luteal serum concentration of progesterone required to ensure an optimal endocrine milieu during embryo implantation and early pregnancy after FET treatment. Next. So important to avoid overshooting of the patients with exceeding progesterone concentrations and to rely on individualized progesterone measurements to avoid the increased side effects and lower patient compliance. So does monitoring of luteal progesterone really helps or really improves pregnancy outcomes? So this was the original research article published in 2025, latest article in Frontiers Endocrinology. And in this article, retrospective analysis was done on 1,257 cycles involving 942 patients undergoing HRFET. Starting in 2019, they have assessed P4 levels before ET day and then adjusted as per the vaginal progesterone when P4 levels were less than 10 nanogram per ml. In 2021, subcutaneous progesterone was routinely added alongside the vaginal progesterone, with subcutaneous doses increased if P4 levels were less than 10 nanogram per ml. Next. So as we can see here, that individualizing luteal phase support based on serum P4 levels on the day of ET in HRFET cycles especially may enhance the pregnancy outcomes, and rescue protocols actually allowed the patient with low progesterone to achieve similar pregnancy outcomes as those with the higher P4 levels, those who already have more than 10 nanogram per ml levels. Next. So individualized luteal phase support normalizes live birth rate in women with low progesterone levels. This is again the this is the same discussion and being concluded the same, that in HRFET cycles, we should measure the levels of progesterone on the day of ET or one day prior to ET. Next, and we should try giving rescue protocol if the levels are below less than 10 or less than 9.5 nanogram per ml. So same being discussed in this article published in 2018 in Fertility Sterility. Next. So is luteal phase support, P supplementation is also required in natural cycles or not? So this was the article published in Fertility Sterility 2023, which actually assessed the effect of progesterone supplementation for luteal phase support in natural cycle. Because in natural cycle, already corpus luteal is being formed, which releases progesterone. So is there really a need for giving further luteal phase support progesterone? So this study, the main outcomes were live birth rate and clinical pregnancy rate, and the secondary outcomes were miscarriage rate. 4 RCTs were included, involving 1,116 participants. And to conclude, overall, moderate quality evidence suggested that yes, progesterone supplementation for luteal phase support was associated with increased live birth rate and clinical pregnancy rate even in true natural FET cycles where corpus luteum is being formed naturally after rupture of the follicle. So why to look for other FET protocols if already we have natural cycle FET which has good live birth rate? Because in natural cycle FET protocols, it is associated with inflexibility. We need to closely monitor endometrial thickness, follicle size, hormone levels, and it may require multiple blood tests and 7-day IVF clinic availability. Also, it is associated with higher cancellation rates due to difficulty in pinpointing the timing of spontaneous cell surge and ovulation, and requirement of ovulatory cycles in the female partner. So, true natural cycles actually rely on LH surge documentation with daily or frequent endocrine monitoring of LH, estradiol, and progesterone with or without serial ultrasounds to confirm ovulation. And as we all know that LH surge begins when it rises by 180% above the most recent serum values and continues to rise thereafter. So first LH of 17 international units per liter as published in 2017 study in the follicular phase is associated with 30% drop in the estradiol. So we all know that ovulation occurs 24 to 36 hours after the spontaneous LH surge, while 36 to 48 hours after the HCG administration. So FET can be scheduled on ovulation plus 5 day or LH plus 6 day in true natural cycles and HCG plus 7 day in modified natural cycle protocol using the blast stage transfer. Next. So alternatives like natural proliferative phase protocols, it allows flexibility of the HRT cycles as progesterone can be initiated in a wider range of dates during the last days of the proliferative phase. So if during monitoring, a spontaneous LH surge is detected on a Sunday, that would determine FET taking place during the following weekend in true natural cycles. In NPP, progesterone might be initiated the same night and then frozen embryo transfer can be scheduled the following Friday. So it is possible to avoid weekends, working weekends, running IVF clinics on weekends with this natural phase proliferative cycle instead of two natural cycles. So this was the article after just before this current study was published. It was published in 2024 November, Reproductive Biomedical Online, and it was done to compare the ongoing pregnancy rates between natural proliferative phase and modified natural cycle protocols in frozen blast transfers. So it was a retrospective cohort study which was done between June 2022 to June 2024. In modified natural cycles, dominant follicle when it was 14 to 21 mm and ET was more than 7 or 7 mm, and when serum P4 levels were less than 1.5 nanogram per ml, recombinant HCG was given 250 microgram, and vaginal progesterone was administered 200 milligram thrice daily, and it was initiated 4 days after HCG trigger, and blast transfer was done on HCG plus 7th day. In NPP protocol, vaginal progesterone at the same dose was initiated in the when the same criteria were met, that is ET 7 or more than 7 mm, and blast transfer were performed 5 days after starting P, that is on the 6th day of progesterone, that is P plus 6 day. Blast transfer were performed on the 6th day of progesterone exposure, as we do in HRFET cycles. So this study included 52 cycles, 17 were NPP and 35 were modified natural cycles, and no significant difference was seen in terms of positive pregnancy rates, clinical pregnancy rates, or ongoing pregnancy rates. But still, further RCTs or cohort studies with larger sample size were necessary to avoid any kind of error and establish the non-inferiority of the newly implemented NPP protocol. And that's why this current study came into birth with larger number of patients and larger number of cycles with NPP protocol. Next. Currently, a protocol has been published recently in 2025, which is being done as a pilot study. Next. To assess the feasibility of a progesterone modified natural cycle protocol for FET, which we are discussing right now. And it started in September 2024, and the results will be published soon in September 2025. So again, in this, they are following the same criteria, but the minor difference is that they are starting progesterone here 200 milligram twice daily. Once the ET has reached 7 or more than 7 mm, and the mean follicle diameter has reached 14 or more than 14 mm, with no evidence of ovulation. So they are also measuring in this protocol, in this pilot study, which is upcoming pilot study, they are also measuring the size of the dominant follicle, which we are not talking about in the current study of the NPP protocol. Next. But the limitation of the current study was that it was retrospective in nature. The potential for selection bias and unmeasured confounding may still exist. And low number of patients in the NPP subgroup, because these were only 342 cycles as compared to HRFET and true natural cycles. So this low number, which may have or might have led the study to be underpowered for the detection of statistical significance. To conclude, natural phase proliferative FET protocols may be in future an effective and safe alternatives to true natural cycles, to modified natural cycles, and to HRFET cycles, while still allowing for the enhanced practicality in patients' follow-up and FET scheduling. However, further investigation is still warranted with prospective studies with large sample sizes and more homogeneous cohort of patients. Thank you.
Thank you
Thanks.
so much, Dr. Monica. Neeti ma'am, please, if you could
Yeah.
discuss.
So, Dr. Monica, you have done a very, comprehensive analysis of this paper, and I'm so glad that you have done this beautiful job. And I wish there were
Thank
more,
you, ma'am.
audience to this. You have put in so much effort. But
Yes,
whatever, what I always feel in these webinars, because they're having day in and day out, it is good to have 20, people who are willing to listen to you and who are willing to discuss and have a good
true,
discussion,
ma'am.
rather than having, 50 and odd people and not listening.
Listening, yeah.
So, yeah. So now coming back to your paper,
Yes, ma'am.
so there are a few things to learn from this paper. One is that whenever we do a study, this kind of study, you can only have such numbers if you have less inclusion criteria. You
Yes, ma'am.
realize their inclusion criteria were so narrow, and that's why they could include all the patients, but then that makes your population very heterogeneous. So they have
Heterogeneous.
donor, autologous, PGTA, and without PGTA, day 5, day 6,
Day three, yeah.
year of the this thing also. So
Yes,
very
ma'am.
heterogeneous population. But then they did the, and if you are taking that kind of population, then you have to do a good regression analysis. So this
Yes,
is
ma'am.
for all of us to learn, that if we are doing a study and we need more numbers, then you can include all the patients, but then you have to remember that confounding variables have to be taken care of by a regression analysis, right? Acha, one thing is that a lot of assumption. We are just discussing, Monica, okay, because you are
Yes, ma'am.
presenting this paper. A lot of assumption went into this NPP protocol that a corpus luteum must have formed, right?
Yes, ma'am. Yes, ma'am.
Did they find out on ultrasound whether the corpus luteum was there in all the patient, or just few patient, or on during pregnancy scan they found a corpus luteum? What did they do for that?
They followed all the pregnant patients, those who got positive pregnancy results. They followed the formation of corpus luteum in those patients, and they found that yes, corpus luteum was there, was formed. But
Yeah.
then again, it was not done on all the patients because those who got positive pregnancy results, they followed in them only.
And as far as I remember, in this protocol, they are also seeing the size of the follicle also, na? 14
No, ma'am. In this current study, they are not seeing the size of the follicle, neither they are seeing the value of LH surge. So that's why it's better in terms of flexibility and monitoring. But the recent protocol, which is being published and
But
upcoming study,
but the things the diagram which you showed initially,
yeah, in that diagram they have mentioned, ma'am. I think they have mentioned it by a mistake or it was a generalized, like general
because they
schematic.
have to be very clear on this, whether
Yes,
they
ma'am.
saw the size of the follicle or not.
Yeah. So I thought of also erasing or like, but I didn't get time to remove that. But in the text, they have clearly mentioned that they, in this protocol, they haven't either mentioned like monitored the size of the follicle. They have started vaginal progesterone 400 milligram twice daily when ET was 7 or more than 7 millimeters.
Yeah. So now that also makes it very tricky, because the whole premise of a natural cycle FET is on having a corpus luteum, right?
Yes, ma'am, you're right.
And if we are not seeing that the follicle has reached a size of 14 or not,
How can we be
how can
sure
we
that?
be sure
Yeah,
that we
yes,
made a
ma'am.
corpus luteum when we are not even seeing it after
Yeah.
transfer? Secondly,
Mm.
what I was thinking was, did they mention how many days of follicular phase? Did they have a certain minimum number of days of follicular phase when they started progesterone? Or suppose a patient has a endometrium of 7 on the
Yes, ma'am.
8th cycle. Did they start
Yes, ma'am.
progesterone from that day?
They have started progesterone from that day, but they haven't mentioned days that how much days it went in all patients because they were very lesser number of cycles. Only 372 cycles were included in the NPP.
Yeah. So you realize why I'm trying to bring
Yes,
out this
ma'am.
thing is
Yeah.
that even if a study is published in Human Reproduction Update, which
Yes,
is
ma'am.
the best journal for
Yeah,
all
ma'am.
of us, there
Yeah,
could
yeah.
be certain things which may still be missing there, right?
Yes, ma'am. Yes, ma'am.
So they have, in the figure they have shown, they have seen the follicle diameter,
Follicle, yeah,
but when
size.
they write that they haven't seen. So we are
Yes,
not
ma'am.
clear. Probably they might have seen. I
They
don't.
have tried to like combine HRFET protocol, like we in hormone replacement cycles, like we usually do, we start vaginal progesterone or progesterone when once the lining has reached 7 or more than 7 trilaminar. So they have kind of mimicked both the protocols, like true natural cycles and HRFET, and just to avoid minimal like monitoring, to have more flexibility. So they have kind of they are trying to convey this message that we can combine the advantages of both the cycles, both the protocols, and then we can bring up with a third best protocol.
Yeah.
Because again, in ma'am, modified natural cycles, when we are giving HCG and we are sure that ovulation has occurred, or even if we are monitoring or looking for the evidence of ovulation after HCG trigger, but then HCG actually causes some kind of asynchrony. It's true between the like endometrium and the natural ovulation, which is actually occurring with the growth of the follicle.
Normally when you in a modified natural cycle, if you will give HCG,
Yes,
you have to
ma'am.
check at the LH surge, won't you? What do you do in your practice?
Ma'am, usually what we used to do in AIMS, when we used to give practice this modified natural cycles in few number of patients, those who have ovulatory cycles, of course, then we used to measure the size of the dominant follicle. When once
Yeah.
it has reached like 18 to 20 mm, then we used to give HCG without monitoring
So
LH.
what we normally do is that if we the size has reached say 17, 18 mm, but the LH has still not risen, and I
Yes,
want
ma'am.
to time my cycle, time
Yes,
my
ma'am.
transfer. That
Mm-hmm.
is when I give a SCG. So
HCG,
that
yes,
is the
ma'am.
kind of modified natural we do. So
Yeah,
we
yes,
always
ma'am.
look at the LH surge, and if the LH surge has happened, then you can't usually should not do a
You should,
modified
yes,
natural.
ma'am. You
Let
should not
the
give. Hmm.
naturally the ovulation happen, and
Hmm.
this thing happened. So very difficult to. What do you think? What do you think? Will you be able to take this kind of protocol in your practice? Let's see. What do you have to say about this?
In private practice, in my experience, it's very difficult to adapt to natural cycle protocols because it really requires a lot of monitoring, ultrasonic monitoring, as well as hormonal monitoring from patient point of view. And many working ladies, they are not uh, willing to visit us daily because at the end of the in the late proliferative phase, it is almost, ma'am, daily monitoring of the serum LH levels and daily monitoring of the follicle through ultrasound. So currently, in my experience, it's very
Are you ready to take up this protocol in your practice? Are you confident after this study?
yeah. Ma'am, like in research institutes or in bigger institutes, we can and we should because seriously, we should think of developing a protocol which actually creates corpus luteum and then decreases the maternal morbidity because our aim is to decrease maternal morbidity during pregnancy. So we don't want only to give a positive pregnancy result, but a healthy pregnancy also. So to
Yeah,
give healthy pregnancy, corpus luteum should be formed and we should all try to inculcate such protocols in our practice.
yeah.
Dr. Monica had one doubt.
Hmm. Yes, Dr. Ankita?
Study, they have not monitored like they have not checked whether the ovulation has taken
No,
They
place
have
or
checked
not.
in those patients who got pregnant actually. In early pregnancy scan, they have checked in pregnant patients only.
and
No,
they're
no,
saying that
I got
sometime
that
we
point.
saw,
I'm
sometime we
asking
saw.
what
Yeah,
Dr. Neeti ma'am was asking, that
Hmm.
if we're not checking the corpus luteal is there or not, like we're checking only for the pregnant females, right?
Yes, yes,
That
yes.
means that the corpus luteum was maybe the ovulation did not take place in the patients
Hmm.
who did not become pregnant.
Hmm.
Because we
yeah,
have not checked
Yeah,
only
yeah,
that the
yeah.
ovulation has
Maybe.
taken place or not. That was the whole purpose of the modified natural
Hmm.
cycle, right?
They have just assumed and they have written one line that they have assumed that ovulation might have occurred in all the patients because miscarriage rates and live birth rates were equivalent to the true natural cycles. So they have just assumed it. But
Yeah,
they
that
should
is what
have,
Neeti ma'am was saying, that a
yeah,
lot of assumption is there. So, like,
yeah. This is
practically
the
using
drawback.
it in day-to-day practice, like our purpose of doing modified natural is that we want to ensure that the corpus luteum is there
Is
and
there.
which is supporting the pregnancy.
Actually, yes,
So,
yes.
true natural cycle we may not be using, but modified natural cycle will be still useful. But this
Hmm.
NPP, whether we should use in practical terms or not, that we don't know.
yeah.
Yeah, we
So
can.
my take on this is, what the take home message maybe could be that, the world has moved and we also have majorly moved towards natural cycle FET now. Okay.
Yes, ma'am.
And in anovulatory patients also, we are using stimulated cycles,
Yes, ma'am.
including letrozole or even gonadotropins. Okay.
Gonadotropins. Yes,
To
ma'am.
stimulate, we're doing that. So this thought process about having a corpus luteum now is very important, and we know
Hmm.
that it has implications. So
Yes, ma'am.
artificial cycles are being used, if at all, for the feasibility, that
Hmm.
they are easy, maybe for the outstation patient when they come
Yes, ma'am.
prepared, because they can't
Hmm.
come for monitoring so very often.
Yes,
So
ma'am.
these are the patients where, we are thinking of doing an artificial cycle. Otherwise, we have majorly moved towards a natural cycle.
Yes,
Now,
ma'am.
comparing natural cycle versus vis-a-vis modified natural definitely reduces the amount of monitoring which you have to do.
Hmm.
But yes, there are studies which have shown that natural cycle might be better than modified natural.
Modified natural cycles. Yes,
Yes,
ma'am.
there are studies which have shown that. So
Yes, ma'am.
yes, modified natural does give you that feasibility, but
Hmm.
we have to take that in mind, that literature does not really 100% support that they're both
Yes, ma'am.
equally good.
Hmm.
As far as this protocol is concerned, now, if at all, I want to do this, that I don't want to wait till 17, 18 mm, I
Hmm.
don't want to keep calling my patient,
Yes, ma'am.
why not give a HCG at 15 mm, 16 mm,
Yes, ma'am. Yeah.
and do that protocol? What they call it, a flexible HCG protocol. They
Flexible
call it
HCG
flexible
protocol.
HCG
Hmm.
protocol.
Hmm.
Suppose you don't want to keep monitoring
Hmm.
for a long time and calling, then at 16 mm, give a HCG and then plan accordingly. We are
Yes.
be doing a starting progesterone directly.
Yeah, randomly, like at any day when ET is
Exactly.
ready. They are starting randomly progesterone
Randomly.
once ET is
And
ready.
this without monitoring follicle size, so is completely, I don't know. I can't imagine this, that because at least we would like the follicle to reach 14 mm. To
Yes, ma'am.
believe
When we are
that,
doing a scan, then why can't like
yeah, and
we measure both
to believe that
how
it
much time it will take to measure follicles
uh,
simultaneously when we are measuring ET?
to believe that it will make a corpus luteum which will feed my pregnancy. So
Yeah, yeah.
at least 14 mm size should be reached, first thing.
Yeah.
And I
Hmm.
feel the duration of follicular phase is also important, which you mentioned in your last study, where the protocol which you mentioned, that
Yes, ma'am. Yes,
10 to
ma'am.
12 days of cycle.
They
Yeah,
have mentioned it.
10
Yes,
to
ma'am.
12 days of cycle, when the endometrium has reached 7 mm and follicle is 14 mm or above, they
Hmm.
are starting progesterone.
Hmm. Maybe, ma'am, this upcoming study, will be able to remove the drawbacks of this current study, and we will be like discussing it in September, or maybe end of September 2025. So,
Yeah. But great effort, Dr. Monica. It was nice interacting with you.
thank you,
Dr.
ma'am.
Ankita, do we need to take any questions?
Neeti ma'am, there are some questions in the chat box. If
Ask.
Monica can answer and you can discuss. But
Yeah.
I had one doubt, something similar to this. Ma'am, if you're doing a modified natural cycle and we have given trigger to the patient and there is a corpus luteum, the ovulation has taken place, we have documented. Still, should we give progesterone or not? That is a
Yes, yes, yes.
controversial.
Because now, see, she showed a study also, na, and they are saying that even in purely natural cycles, progesterone luteal phase support does make a difference in terms of live birth rate. She showed a
Hmm.
study, where they
Yes,
said
ma'am.
that whether luteal phase support should be given or not. What is
Hmm.
important for all of us to remember is that when we are talking about luteal phase support in a natural cycle or a modified natural cycle, please restrict yourself to vaginal progesterone.
Yes, ma'am. Yes, ma'am.
200 milligram twice daily or 400 milligram twice daily, whatever suits your
Hmm.
practice. But you know, restrict yourself to vaginal progesterone. No second route is required.
Yes, ma'am.
When you are giving a HRT cycle, then you might think of adding another route, or
Two
you
modes
might
of progesterone. Two
and
routes
you
of
might think of doing a progesterone level and rescuing
Hmm.
it. And there
Yeah.
is a lot of evidence on that, which is called personalized ETs now, no?
Individualized
So
LPH.
yeah, individualized ET, personalized ET. So there's a lot of evidence to that. So we should monitor if we are doing a assisted HRT cycle, should be done. But for a natural cycle, only vaginal progesterone.
Yes, ma'am. Yes, ma'am.
So that this is what I think, Ankita. I don't know if you differ on this.
Thank you so much,
But
ma'am. No,
natural,
ma'am, absolutely. I
yeah. So
understand. So
modified
that's the reason
natural
I
has,
think many of the people have these questions. That's the reason I was asking this thing.
Yeah,
So
Dr.
one of
Deepika.
the question in the chat box says that can we start progesterone externally when the LH surge has occurred, but P4 is still less than 1 nanogram per ml?
Yes, ma'am, we can start progesterone because this is what true natural cycles are based on. Because once we have seen that LH surge has occurred to a level, and then serum estradiol has dropped 30% to its initial value, and P4 is still less than 1 nanogram per ml, then we should, in fact, we can and we should start progesterone that day.
Okay. And the next question is in mild stimulation FET, which I think they're talking about letrozole FET
Letrozole
maybe.
stimulated.
Dominant follicle is 18 millimeter, but ET is less than 7 millimeter. Can we add antagonist?
Dominant follicle is 18 millimeter and ET is less than 7 millimeter.
I think they want to ask if the ET is like, we want the ET to reach 7 millimeter and we don't want the
Yeah.
follicle to rupture. Should we
So
give antag or
if
not?
you want to add antagonist, then you will have to give gonadotropin also, right?
Yes,
In
ma'am.
a natural cycle, you're doing it.
In
What?
mild stimulation FET, Dr. Manisha has asked for if
Huh.
dominant follicle is 18 millimeter, but ET is still less than 7 millimeter. So can we add antagonist?
Yeah, you can try that, doing that to stop the LH surge, but in that case, you will have to add a gonadotropin also if you want to do that kind of tweaking there.
Hmm.
So you have to add gonadotropin and antagonist.
And ma'am, can we like see if it's 18 maybe it can reach 20 millimeter. Along
Yeah,
with that, we can give estradiol, like
Yes,
a
ma'am,
little more
because
estradiol, even if it's a natural cycle, but only for the last 1 or 2 days. Can we give estradiol to improve the lining?
estradiol, supplementation in a modified, in a stimulated cycle. I have usually not done that in my patients that I have given estradiol to increase the endometrial lining. No, I haven't done
Okay.
that.
But in this sense, Dr. Monica, if you want to add, means I'm
yeah, ma'am,
talking
we
about like
have
from dominant follicle 18
yeah,
millimeter to 20 millimeter,
yeah.
and we have 1 or 2 days time, and if we can give estradiol validate 2 milligram once a day or twice a day,
Yes, ma'am. So,
will it
like
affect or not?
we used to add estradiol, and then once the size in letrozole stimulated cycles, once the size of the dominant follicle has reached 15 or more than 15 then there will be very less chances that this estradiol will actually affect the HPO axis in a negative manner. So it will not affect the development of this 18 millimeter follicle now, but it will add to the endometrial thickness. And we can also give antagonist to rescue these kind of cycles, but I have never done myself. But I have added estradiol in letrozole stimulated cycles, and it worked for me in some patients.
Yeah, Neetima, me too. Means I've not used Antag, but I've added estradiol in
Yeah.
letrozole FET cycles after the dominant follicle reaches like 15,
Yes,
16,
ma'am.
as
Yes.
Monica said. We have tried that.
Okay, okay. But you know what, Ankita?
Yes,
I
ma'am.
I've also realized that sometimes, the endometrium lags behind even in letrozole cycle, the way it does in clomiphene cycle. It
Clomiphene
does happen
cycles.
with letrozole,
Hmm.
but with letrozole, it catches up, you know.
Yes, ma'am.
So if you
Hmm.
let the follicle grow,
Hmm.
catches up. Even in IUI cycles, if you see, if you
Hmm.
let the follicle grow, it catches up. The same way as in cycling cycle.
But the size has
Okay, ma'am.
reached to dominant, like to dominance, 18 millimeter, then there is
Yeah.
chance of rupture, also spontaneous rupture. So to
Yeah.
prevent it, maybe 1 or 2 doses of cetro is required. Maybe someone can else can answer who have
You
experienced
know,
it.
in letrozole cycle, I have not given antagonist actually
Okay, ma'am.
because already the E2 levels are very low, so I don't know how the antagonist and then adding a
Yeah, it is too much to salvage the cycle, actually.
salvage the cycle. Yeah.
Yeah, yeah.
I think we need to close. Are there more questions? Because I'm getting calls from labor room right now, or maybe I can leave.
No, no, ma'am,
I
it's
can
fine. I
continue.
think we are done with the questions. Thank you so much for your time, ma'am, and sorry for the delay. I'm really sorry for
Sorry,
the delay.
dilemma.
Okay, and I'm glad that at the end of the day we were able to have a good discussion on
Neeti
it.
ma'am, I have one question. If 1 minute. Uh,
Yeah,
Hello.
Priyanka. Yeah,
Ma'am, actually, I want to know one thing. If LS surge has happened, okay,
yeah.
we are correlating with the follicle, LH surge has happened, and somehow next day when we see the LH has come down, but my progesterone is not more than point 0.8. And the follicle in the morning when we did the scan, the follicle has not ruptured. That sometimes is a dicey situation. Should we start the progesterone by the evening or wait for one more day? Or because meanwhile progesterone is point 0.8, something like that value.
See, you will get all these kind of tricky
Yes, ma'am.
situations. Normally what is expected is that your LH surge starts if the next day you see the LH will peak, right? So
Right.
it will be more than 18, 20. Next day you will see it will become 40, 50 or something
50
like
also.
that.
Yes,
And
ma'am.
next day after that you will see the
Tapering.
yeah, it will come down, LH will come down, progesterone will rise. Okay, some every time, and that's why it is so important to correlate with ultrasound. Like the
Hmm.
other person was asking if the progesterone does not rise. It happened in one of
Hmm.
my patient. I saw the follicle ruptured, but the progesterone is still 0.8. So,
Yes.
sometimes it could be a lab, this thing also,
Yes,
Right.
ma'am.
because the surge was there, the peak was there a day prior, and then a day after the peak of LH, I find that the progesterone is only 0.8, but the follicle has ruptured. So I take it
Hmm.
as a ovulation day, and I continue progesterone, and you know,
On the same day, ma'am. And my what if follicle is intact, my progesterone is low, and then also I can start on the same day progesterone if the previous day LS surge has happened and
I
LH has
think so.
fallen
Now
down.
they're saying that without, at 14 without any surge, without anything, they are giving progesterone and doing a
Yes, ma'am.
transfer.
Yeah, yeah.
Yeah,
So
ma'am, we can
Simultaneously,
do
we
it.
can also monitor serum estradiol levels in true natural cycles along with LH. So maybe we can then correlate both LH and estradiol levels to know,
T2 is
actually
falling to
help us to
30%.
know
yeah,
whether
that can also be
that
done.
surge has occurred or not.
Okay,
I
thank you
think
so
Neeti
much.
ma'am, we can
I'll
close.
have
I think
yeah,
it's
thank you.
Okay, ma'am. Thank you so much.
Okay, ma'am. Thank you so much. Thank you, Dr. Ankita.
thank you everyone. Thank you, Dr. Monica. Good night.
Okay, good night.